So thank you, everyone. It's really a pleasure to be here on one of these Tuesday lectures. I've been really looking forward to talk a little bit more about our research and what we've been doing with the acute groin injury so far, and there's still more to come on top of this. So today I'll go through the studies which are part of my PhD thesis, and so these will all be related to the diagnosis of acute groin injuries. We're supposed to also have studies on the treatment, but we're still including those, still including patients for those studies, so we'll be able to put it a little bit more into perspective the findings that we have today. And the PhD is submitted. It's in PDF form, so if anybody wants to read the whole thesis, just send me an email and I'll send you the PDF. We have a few copies in Copenhagen when I'm going there next week. So if you really want a hard copy, I'll try to bring as many as possible back. So there are many reasons why I'm here, but probably one of the main reasons is that I used to play football. In about 10 years ago, we just got promoted to the second division in Denmark, which is decent. And we had a good preseason, but then the last game before the league started, I got a groin injury. So an acute groin pain, right side. Important that we start off well, so I was keen to get back to the team and to playing, and ended up going back a little bit too soon, so I got another injury, so a re-injury, same injury. All right, so we'll take a little bit more time off, but still keen on wanting to play. I continued to playing, had a little bit of pain, the pain got worse, and then all of a sudden I had to stop. So then I was out. I couldn't play, I did the evidence-based program, didn't help, and I ended up being out for the rest of the season. So I have experience with both the acute pain and the long-standing groin pain, and this is what made me get into this field. So through my physiotherapy degree, my master's degree, groin injuries have been my main area of interest. And hopefully we will be able to move the field further, so other athletes like me and better athletes could benefit from the research that we're doing here. So of other athletes, we have a guy from Barcelona who here has to stop playing. You'll see him in the middle, gets into a little tackle, change of direction, can't really clearly see what's happening, but he has an acute pain that's sufficient for him to get out of the game. So the team is not happy. He's in pain, he can't play on, has to get substituted. So now it's up to the medical staff to figure out what's his diagnosis. So without knowing too much, we found out that he has a groin injury. I tried to find the situation in the movie where I think it happens, when he's reaching for the ball and gets a little bit pushed, stretch in the back, and the pain comes in the right side. So it's not only me and Messi who gets groin injuries. There are other good football players as well, like Ronaldo. So we got a lot of good football players, best in the world. So as a research mind, you'd be able to think, okay, maybe groin injuries are related to skill. But then I realized that there was a reason why I was in defense. So probably have to look elsewhere. And we can see that there's a lot of other people getting groin injuries. Up to 19% of all groin injuries in football. In the QSL here from Andreas' data, we can see that in the QSL, it's 18% of all time loss injuries. And we know that groin pain is more than time loss. So a new study from Norway showed that almost a third of all players, football players at different levels, will have some form of groin problems every week. So very high prevalence. So from some research, Ekstrand and co, we can see that every season in a team of 25 players, you can expect 4 muscle injuries per team. So that corresponds to about 16% of all players will have an acute groin injury, acute muscle injury every season. So a lot of people. So if we look in the world, if we estimate that there's about 265 million people playing football, that will correspond to about 40 million acute groin injuries per year. And it's not only in football. We also have other ball sports mainly with a lot of change direction, kicking, and so on. and most of those will have around 10% of all time loss injuries being acute groin injuries. So potentially we're looking at more than 100 million groin injuries a year. So we'd assume that there should be some research on this. And there is a bit, but when we look at the epidemiology, we're really, really limited by the terminology that you use, that we use within groin pain. So a lot of different diagnoses for the same symptoms. And this gives us a poor overview of the actual injuries that we're dealing with and how frequent it is to have pain in different locations, as well as figuring out how to improve the management. So while I was here, we also did a systematic review on the management of groin pain, and in that study we included 72 studies, and we saw that 33 different diagnoses were used. So a lot of these were different different injuries, so actual different injuries, but a lot of them were also just different names for similar symptoms. So that really is a problem within sports medicine and groin pain. So a couple of years ago, trying to move this further, Aspetar leading the way with the Doha Agreement that I was lucky to be a part of as well. But within that agreement, that was focusing on the long-standing groin pain mainly. So we still have a lack of evidence in relation to acute groin injury. So I hope the research that we've been doing here can move that a little bit further. Yeah. But when we're talking about terminology, we'll go back to Ronaldo's injury. First, we got to figure out where is the groin. So we're a full room of sports medicine professionals, and I'm pretty sure that there's a lot of different opinions on where the groin actually is. So something that we think should be so simple might be very different between us. So if we look a little bit closer at Ronaldo's groin, some would say that the groin pain would be around the pubic symphysis. Some will say it will be around the inguinal ligament. Some will say it will be in the adductors, and some will include the whole region in the anterior of the pelvis and the hip. Yeah. So even though I've been working with groin pain for such a long time, I'm actually not able to give you the exact answer as to where it is. But the closest we get is the mesh turn, which defines the groin as the external junctional region between the lower abdomen and the thigh. Yeah, so we're in the region, but we don't really have any anatomic borders that we can say this is the groin. We have some different research, cadaver studies and descriptive studies trying to give us a better picture of the area and which structures are involved. And these can kind of be blocked in different areas. So we're looking at the hip flexors. We have our iliopsoas, rec fem, sartorius. Sometimes the TFL is included, although it's a little bit more laterally. We have our abdominals, different layers. And we have a number of adductor muscles. So within this region, we have a lot of different structures which could potentially be injured and causing pain. Yeah? So how do we figure out how to get further from there? How do we diagnose these injuries? Can we do it just based on our patient history? So just talking to the patient, how did it happen? And doing our clinical examination test, or do we need to use a little bit more extra time, a little bit more extra money doing an ultrasound scan, or even more time and money in doing an MRI? So as any good clinicians, you then go to the research. So we did that when I came here, and just a very, very rough search will tell you that there's not a lot of evidence related to acute groin injuries here. Here are only 2 studies with this rough search. But the main point is not a lot of evidence. So I'm hoping that we can add to that. If we're looking at these two studies from the search, we can see the best of those, more specific related to the diagnosis, was from Extran in 1999. But when we look in a little bit closer into to the article, we can see that there wasn't any description of any clinical examination test. So that's not very helpful as a practitioner. And even more surprisingly is that they described that 19 out of 25 of these cases were actually of gradual onset. So we're not really dealing with acute injuries in this study anyways, and only 1 could be confirmed by ultrasound. And that's because of a large delay between the injury and the examination. So we think we can do better than that, and hopefully I'll be able to show you how we did this with these 5 studies, or with 5 studies that are included. So just basic what these 5 studies involve is, first we wanted to provide a general diagnostic overview. Then we wanted to look a little bit more into the MRI and see if we can trust the MRI scans and the reporting of the MRI scans mainly. We wanted to look a little bit closer onto the clinical examination test. How do we interpret those? And then we looked a little bit closer into the MRI again and figuring out, are there any specific injury characteristics which might be helpful for our diagnosis and our subsequent management of these injuries, as well as our understanding of how these injuries occur. And we did this in 2 different studies, with one looking at the adductors and one looking at the hip flexors. But I'll get back to that. So to set it up, we have an overall process for this study where we're looking at different elements in the different studies, but generally they all follow these overall methods. First, we're here at Aspetar, so all the athletes, all the people involved are from Aspetar, so original clinical research from Aspetar, which is a key point. And this wouldn't be able to be completed without the help from all the guys at the National Sports Medicine Program. So the direct access that we have and the collaboration that we have really enables research like this, and I'm truly grateful for that. So whenever the guys have an athlete with groin pain, they'll get seen in the walk-in clinic immediately. It could be a day after the injury. And the sports medicine physicians will then figure out this is an acute groin injury, give me a call, and I'll go running and see if this guy wants to be part of our study. So this is the main part of the inclusion. The inclusion criteria was that we have to be male athletes, so registered athletes in Qatar from any kind of sports, adults, so between 18 and 40. And they had to have acute groin pain, and it had to happen during sports, so nothing where they slip in the bathroom and feel a little pain, or often they'll explain that it wasn't really acute, but it came sneaking in and got worse after training. So we excluded those to get a more clear picture of the guys with acute onset pain only. And they had to have the initial examination within a week after the injury. And that really sets us apart from the other study that we talked about earlier. And we can see we have the different studies, a bit different inclusion periods, not so important, 2 or 3 years for each study, but in total this duration is over 3 sports seasons. We have a different number of athletes in the different studies depending on our aims and hypothesis. And we can see that the majority of the guys were football players. So 3 out of 4 were football players, and then some other athletes from other sports as well. So within the football players is a number of futsal players as well, but football in general. So when they come in, they have a clinical examination. We have a standardized registration form that we use in the walk-in clinic, where the sports medicine physician that's on duty it writes in all the injury information, comes up with a diagnosis, both a specific diagnosis and a diagnosis categorized into the different areas with adductor, abdominal, iliopsoas, or proximal rec-fem injuries. We then have an additional standardized clinical examination where we have described tests performed exactly the same every time. So that was with me after the sports medicine physician, where we have a number of palpation areas, stretch test, resistance test, and the full described protocol is in one of the studies. So if you're looking for a little bit update on the examination, I'll be happy to forward that to you as well. Following that, we get an ultrasound examination. Unfortunately, we're only able to do that as part of study 1. We had to discontinue the ultrasound examination due to some logistical reasons and other reasons. So those will only be part of study number 1. And so the main thing will be the MRIs in these studies. So we had 8 standardized sequences in different views. So we get a really clear picture of the extent of the injury and the location of the injury and that we have here. So moving straight to study 1, what we wanted in study 1 was to just describe the injury situation. So how did these players report how the injury happened? Can they remember, and which situations do these injuries occur? We wanted to provide an overview of the clinical diagnosis, and we wanted to show the distribution of injuries in both the ultrasound and the MRI. Following that, we then compared the clinical diagnosis to the MRI findings and see if there are any differences there. And in total, in this study, we had 18 different sports medicine physicians, including these patients and examining these patients. We had 9 different radiologists being involved in daily practice. So that's also some of the unique things about being here, that we're so many smart minds. But this could be a potential limitation in terms of the reliability of the reporting of this study. And we'll go straight to the results. We can see that the acute groin injuries in general happen mainly during kicking, change of direction, few stretch and reaching situation, and some in sprinting and running. But mainly kicking and change of direction. So these are the elements that we need to look a little bit closer to. And we've divided into different sports. We have football. We have about 40% of the injuries happen during kicking, and then change of direction following that. And in other sports, of course, there's not a lot of kicking in there. The main injury situation is then change of direction. So this is where the acute groin injuries happen. And when we look back to Ronaldo, we can see in our overview that 2/3 of the injuries happen in the adductors. So two-thirds of any acute groin pain will be located in the adductors, regardless of which way we're examining, whether it's clinical examination or the ultrasound and the MRI. For the positive cases, this is how it is. And the majority of these are located in the adductor longus. So 9 out of 10 will be in the adductor longus. Will be a main focus for us. We see that there's also quite a lot of both the iliopsoas and proximal rectus femoris injuries. We didn't include the whole anterior thigh, but just the ones in the groin region. And we can see that there's a higher amount of injuries in the clinical diagnosis than in the imaging for both the iliopsoas and the rectus femoris. But we'll get back to that afterwards. Interestingly, in the iliopsoas, our imaging reports show that there are more injuries to the iliacus muscle. But we'll get back to that as well. Few injuries in the abdominals and sartorials, usually in combination with other injuries. But also very importantly is that we have 1 in 4 cases which are negative in the imaging. So then we really have to rely on our clinical examination. We can't always expect to get the results just by sending the player to the MRI or ultrasound for that case. So then we compared the clinical diagnosis to the imaging findings, and just to summarize those, the main finding that we saw is that the adductor injuries were usually confirmed by the imaging, whether it was MRI or ultrasound. But if we look at the amount of diagnosis in both the iliopsoas muscle and the rectus femoris, we can see that there was actually an injury in a different location and not the diagnosed location in more than 1/3 of the cases. So that tells us there's something difficult about diagnosing these injuries in the initial examination. So we, of course, wanted to look a little bit closer into that. First, or let me just summarize the study 1 here, sorry. Injury situations, main things to focus on: kicking and change the direction, just both in terms of understanding the history, preventing the injury, as well as progressing through the rehab. These are the main elements that you need to consider. 2 out of 3 are in the adductors. 9 out of 10 of those are in the adductor longus. A lot of imaging negative cases we need to keep in mind, and that we have this discrepancy between the clinical diagnosis and the imaging results. So we look a little bit closer in study 2 on the MRI. Maybe it's the reporting of the MRI that gives us this discrepancy. So is there something wrong with the reproducibility? Do the radiologists agree on their scoring? So we described a more detailed scoring protocol for these injuries. So we standardized the reporting of the MRI scoring. And then we tested the inter and inter-rater reliability or reproducibility. and to see how well that was. And we had two different experienced musculoskeletal radiologists. These were all blinded to any patient information. They were blinded to each other's scoring. And the guy that did the scoring twice had 6 weeks in between the scoring, so he couldn't remember directly these images and his scoring related to that. So for that reproducibility, we use a bit of statistics. We use something called the kappa values, ICC values, which will give us a number that will be higher than chance. So what do we expect that is better than chance? Is the reproducibility better than chance? And the higher it is, the closer to 1, the better, and 1 being perfect reproducibility. So this is what we're aiming for, of course. So I'll just show some of the scoring parameters that we had. On the left here, we have an acute injury, and then on the right, we have a non-acute injury. So how we separated those was more clear, focal, hyperintensity. So the white here, this is the right thigh, we have the femur here, and this is the adductor longus muscle with the hyperintensity, the clear brightness representing the fluid and the injury. And then similar right thigh here, also the adductor longus with a little bit more subtle and diffuse hyperintensity, so that we scored as a non-acute injury. We then did this for each muscle. Was there an acute injury, or was there an injury, and which kind of injury was it, and how many muscles were injured? We also did grading, so simple grading from 0 to 3, with 0 being no injury. So here we can see the pelvis from the front. There's no injury here. We have the pubic bone, the right leg, the left leg. It looks normal. Here we have the right adductor longus with a little bit of hyperintensity. We'll call that a grade 1. A little bit more, and we'll probably see it better in the actual images where we have probably a bit of disruption of the fiber. We'll call that a grade 2, a partial tear. And on the right here, a complete avulsion where we can see the insertion of the adductor longus, which is retracted from the pubic bone. So our simple scoring. So just to summarize those results, is that we both in the intra-tester and inter-tester reproducibility, we found really high numbers. So our kappa values were more than 0.8, which is considered very good. And so we think that there's a very high reproducibility of these scoring parameters. So we also measured the amount, the extent of edema, and that's done in millimeters here, proximal to distal, medial lateral, anterior posterior, as well as the cross-sectional area of the muscle with the most edema. We measured peripheral fluid, so all continuous measurements in millimeters. And to summarize those results, we can see that similarly we have almost perfect reproducibility for that. And we're looking at only small variations between the scores, both in the inter and inter-test reproducibility, with about 10 to 20% for each of these parameters. So basically the conclusion of study 2 is that we're happy with the reproducibility when it's standardized, when it's performed by experienced musculoskeletal radiologists. We think it has very good intra and inter rate of reproducibility. So then we want to look a little bit closer to the clinical examination test. So could these be related to the discrepancy, and what other information can we gather from this? So we wanted to examine first if we can predict the MRI results. So can we predict a positive MRI in a specific muscle group? Either a positive or a negative MRI. That's important, we think. And then we wanted to assess the accuracy of the clinical tests. And so we did that by using all the standardized clinical examination test results. And we compared that first to the standardized MRI scoring. And then we took away all the imaging negative cases, because these brings uncertainty, and only use the positive cases as a gold standard to our comparison of accuracy. Yeah. So in terms of that, we also have a lot of different diagnostic statistics. What we'll focus on now is the negative or positive predictive value, or our post-test probability. So what's the likelihood that the player has a certain injury after we've performed the test? So we have a pre-test probability, which we get from general epidemiology, or in this case from our sample size specifically. We then perform a diagnostic test, and hopefully we were able to change our probability of either a positive result or a negative result. So this is what this is about. And this is our sample size here. We can see a lot of different injuries. We grouped these. We have the adductors, almost 57% of those. Our hip flexors, about 22%. So this will be our pre-test probability. So without even seeing the patients, we know that there's a 57% chance that this player has a positive MRI in the adductors. So this would be our pre-test probability for the adductors, and this for our hip flexors. And we didn't look at the abdominals and other muscles because there are too few. And if we look at the findings from study 1, look a little bit different on the numbers, we can see that these are very similar to our overall prevalence of injuries. So first we look at whether we can predict a positive MRI in the adductors only. Yeah, and just highlighting the main results is that the 3 best tests to figure out whether there's a positive MRI was our squeeze test in 0 degrees, so long lever, outer range resistance, and passive stretch in this position. These all have a positive predictive value of around 80%, meaning that if the test is positive, there's an 80% chance that the MRI will be positive in the adductors as well. Yeah? So we go from a pretest probability around chance to about 80%. Unfortunately, we're not getting higher, and this is probably related to the amount of imaging negative cases as well that might have symptoms in the adductors, but the imaging is negative. Yeah, so we also wanted to see if we can predict these negative MRIs. Yeah, and the best test for that was just basically palpation. So if there's no palpation pain, we have a 91% chance that there's no positive finding in the adductors on the MRI. So then we go again from our pretest probability about chance down to about 9% chance in this case that you'll see something. So there's still a small chance that there's an injury, and that's probably related to the difficulty of really defining all the structures in the adductor region. We also have some obturator externus included, for instance, which are really difficult to palpate, if not impossible. And just to summarize in the accuracy, not to go too much in detail, but what we see is in general, then all the tests had a really high accuracy. So if we remove the imaging negative cases, which kind of limits this number, we can see that all the adductor tests have very high accuracy, up to 97%. And in cases where all your adductor tests were positive, in our study it was 100%. So we can be really, really confident in our clinical examination test for the adductors if we just want to know that there's an adductor injury, so an acute adductor injury. If we go over to the hip flexors, we want to predict a positive MRI in our hip flexors as well. And again, just summarizing, all the different tests will have a positive predictive value between 34 and 63. So really not very good. So even though we have our pretest probability, we do our test and we actually improve the chances of a positive result, the end result will only be around chance. Yeah? So as a clinician, that's not really usable, even though we might have a relatively good likelihood ratio, for instance, or positive likelihood. The only case where we say, okay, now we suspect a positive MRI is if all the tests that we did for the hip flexors were positive, and we'll get up to about 86% in our study. We'll go over to trying to predict the negative MRI, and we're a lot better than that, but better at that in all the tests actually. So really good. If the test is negative, there's a big chance that your MRI is negative as well. And with palpation being the most specific for that. And then we'll reduce our pretest probability from 22% down to only 4%. So a very tiny chance that you'll have a positive MRI if your palpation is negative. But then we look at see if we can get better in terms of accuracy. Just to summarize that, we want to define whether we can say that there's a rectus femoris injury or an iliopsoas injury. And unfortunately, our tests, if we're just looking at those as positive or negative, are not able to give us a very accurate result. So in general, we can't really have high confidence in our clinical examination test for the hip flexors in our initial examination. So summarizing these results, the absence of palpation pain. So if the guy comes in, doesn't have palpation pain, he likely does not have a positive MRI. Yeah, for the adductors, we can predict a positive MRI with about 80% chance, and we have a high accuracy also considering the imaging negative cases. Looking at our hip flexor test, they're both poor at predicting a positive MRI and have poor accuracy in defining the actual muscle injury. Yeah. So then we want to know a little bit more about these injuries. Can we get more details that might help in our understanding and in our prognosis? Mainly we're talking a lot about that, and as well as our management. So in study 4, we went in more detail with the imaging of the adductor injuries and looking only at the acute adductor injuries through the MRI scoring. And then we compared the location to the injury situation. So can we see if an injury in different muscles is related to a specific injury situation in the individual adductor muscles? So just to make that short, we can't, in the adductors, there wasn't really any interesting in that comparison. And one of the main reasons for that is, again, that we have so many adductor longus injuries. So again, this is this study overview. We have 87% chance, so again, around 9 out of 10 of the adductor injuries being in the adductor longus, which means that in all the different reported injury situations, the adductor longus is likely to be involved. And we can see that there are often, so about a third of the cases, there'll be more than one muscle injured. But in the majority of cases, there's just one muscle injury, one adductor muscle injury. So now I want to go a little bit more into the adductor longus. This is what you'll be dealing with the most. So we just get a recap of the anatomy. If we look up around the insertion, we have our anterior aponeurosis, which in sports medicine and still in the groin world is a lot of discussion on how these structures are really connected. But if we say that this is the adductor longus, goes into the pubic bone here, follows down the tendon then on the lateral side goes into the muscle, follows within the muscle and becomes completely intramuscular. So we have muscle on each side of the tendon as it goes down, and that's about a fourth of the length of the femur, so individual in terms of centimeters depending on the size of the player. We go down to our distal insertion, which is really poorly described in the literature. I was able to find one picture here where we can see that probably extends more as a tendon aponeurosis around the muscle. But then we look at our injuries. So how are these injuries located in that relationship? So we can see that about a fourth of the injuries are located to the insertion, at the insertion. About a third around the intramuscular tendon, the proximal tendon. And interestingly, we have a lot of injuries at the distal tendon. So more than a third of the cases were actually distal. If we look at the first, the proximal injuries, so the injuries where there's some edema at the insertion, we can see that 75% of these injuries are actually avulsion injuries. So if you find any pain related, any acute pain related to the insertion, we might expect that the adductor longus is detached from the pubic bone. And clinically, you'll be able to feel a palpable defect in most of these cases, but the retraction of the tendon varies, so there can be minimum retraction where this gap is not really palpable, and it actually feels like a continuous structure, but in the MRI, we'll still see an avulsion. So really, this, for me, insertional pain and the extent of the pain that the player reports would justify an MRI or an ultrasound, at least some imaging to guide you further. Then we look at the intramuscular injuries. So what we see in these is that they usually happen in the anterior fibers of the intramuscular tendon here, and we know from the hamstring injuries that there's a lot of focus on intramuscular tendon tears, so injuries to the tendon itself. So with all these injuries that I've seen over these years, I've only seen one case where there was an injury to the tendon itself. So this is likely not very relevant in adductor longus injuries, and in that relationship shouldn't justify any additional images in my opinion. And then here we can see from the distal injuries that the edema is a little bit more lateral and distal, of course, but it also extends proximal into the muscle. And I just tried to put two MRIs here on top of each other. So two different people, one with a proximal adductor injury and one with a distal adductor injury. And we can see that the edema is actually overlapping. So if we do a palpation in our clinical examination, push into the side, usually we'll examine like this, we're not really going to be able to differentiate these muscles or these injuries in the same muscle. So without having any data, if we go a little bit more laterally and go deeper within, this will usually be the distal injuries. So whether those have a different prognosis or a different management, probably the same management, maybe a different diagnosis or prognosis, but we'll figure that out later. So in study 4, we found out that acute adductor injuries usually happen in isolation from other muscle groups, and often several adductor muscles are involved. We know that the adductor longus is again our main injured muscles, and there are 3 characteristic injury locations there. Then we go over to study 5, and we wanted to do exactly the same just for the acute hip flexor injuries, both describing injury characteristics and also looking if there's any interesting differences between injury situations and specific muscle injuries. So summarizing again, this last comparison is that we can see that as we clinically feel, the majority of the rectus femoris injuries, so the proximal rectus femoris injuries, will happen during kicking or sprinting. So these are our main mechanism or main situation for the injuries. And then we can see that all the hip flexor injuries which happen during change of direction will be in the iliopsoas. So this can help us in our clinical management or clinical diagnosis. So if we have a case where we have some differences, a lot of positive results in our hip flexor examination test, we ask the player, how did the injury happen? If he then tells you it happened during change of direction, it's less likely to be the rectus femoris, more likely to be the iliopsoas. And so still a limited amount of numbers, but at least that's the direction of our clinical reasoning based on these findings. We go a little bit more into detail with the anatomy, and I was really fortunate to be part of this dissection in a sports surgical lab here, where we looked at the rectus femoris as part of Frank's study. And a presentation, and we can see this muscle really has a unique structure. We have the proximal insertion with the indirect tendon which attaches to the acetabulum, the direct tendon into the inferior iliac spine, direct tendon going superficially where the indirect tendon extends further down into the muscle, so intramuscularly down in the muscle, and our distal tendon follows up here in the back of the muscle and then goes really high up on the back side of the muscle. So a lot of different areas for muscle tendinous junction lesions, which are what we're dealing with the most here. There's a really nice picture I found on the internet where you can see details of how these tendons extends within the muscle. And we can see here when we're just on the border of the distal area of the groin, if we have to define an area, we can see we have the direct tendon aponeurosis superficially, the indirect tendon within the muscle, and the distal tendon on the back side of the muscle. So at one location, there can be an injury at different areas within the muscle. Again, unsure how much that matters. But from our findings in the study, we had 5 different locations that we see these injuries. So the proximal rectus femoris injuries happen either in the insertion of the direct tendon, the indirect tendon, either at the direct superficial aponeurosis, tendon aponeurosis, the intramuscular tendon of the indirect tendon, and as well we have one case where the player actually had groin pain, but it was on the backside on the MRI, showing that it was actually the distal tendon, even though the pain was proximal. And one of the main interesting findings in these cases is that a lot of these proximal rectus femoris injuries involve the tendon. So unlike the adductor longus, we don't have that many intramuscular tendon tears, but But in the rectus femoris injuries, we often have a tear of the intramuscular tendon itself, or at the proximal insertion. So the indirect tendon is our main injured tendon in these cases. Then we go over to our iliopsoas. We often think as the iliopsoas as a division between the iliacus and the psoas muscle, going down and inserting in a common tendon. But we actually have two kind of bulks of the iliacus muscles. And when the psoas muscles come down, anatomical studies have shown that more often there's actually separate tendons and separate tendons insertions. And in some cases, there are even 3 different tendons going in. And we can see that on this images here, the psoas tendon and the iliacus tendon inserting separately on the femur. So we keep that in mind also for our acute injuries, which we tried to depict in this image. We have 3 main injuries of the iliopsoas. We have the iliacus muscle coming down, and this is actually our main injury area. So of all the iliopsoas injuries that we see, the majority happening here in the iliacus muscle, sometimes with an additional proximal injury as well that we can see here on the inside of the pelvis. There's some edema. As we come down, the psoas muscle is often only injured in connection with the iliacus muscle. We can see here fluid both in the iliacus muscle and the psoas muscle. Same on the imaging, a little round spot here signifying the injuries to each of these muscles. So that could potentially help us understand more about injury mechanisms as well, and potential with the management, that it might not really be related that much to the spine, but more to the pelvis and the pelvic position. So from study 5, looking at the acute hip flexor injuries, we see that the proximal rectus femoris often involve tendinous injury, and this is more often of the indirect tendon. We see that the iliopsoas injuries, on the other hand, happen mainly at the muscle-tendinous junction, and mainly of the iliacus muscle. And we found these interesting differences in the injury situations, which might help us in our diagnosis, with change of direction being the most helpful, and suggesting maybe an iliacus or psoas injury. So just to summarize these 5 studies, we first wanted to provide the general diagnostic overview. Saw that kicking and change of direction were our main findings. Adductor longus, our main injured muscle, and that we have this diagnostic discrepancy. We then wanted to know if we can trust the detailed MRI scoring, and yes, I think we can. Especially here with our experienced radiologists. Can we then trust our clinical examination test? The adductors, yeah, we can, if we just want to know that there's an adductor injury, but not for the hip flexor injuries. And are there any specific injury characteristics? Yes, I showed you the differences in the different types, where some of them might already now help us in our management of these patients. But further on, when we know more about the prognosis, it could potentially also help us with that. Yeah. So that's the end of the studies included in this thesis. I really want to thank everyone who's been involved. There's so many people here at the hospital that's been involved in this study, and it's really too many to mention. I've really enjoyed being part of this large multidisciplinary and multicultural team. All the NSMP guys for coming in and being collaborative, sports medicine department for pushing the study here in the beginning, radiology department for all their help in assessing and discussing the injuries, rehab department for the management, and I'm really looking forward to be able to produce or to present some of the information that we're gathering when we're treating all of these injuries and these athletes. It's all the GSOs who always try to do their best to get these injuries or these athletes in with urgent appointments that were necessary to do this study. And specifically to everybody involved in the Groin Pain Center. It's really a unique place. One of the reasons why I came here, and the main reason why I want to continue to be here. So I'm really looking forward to the stuff that we'll hopefully be able to to move forward and develop in the research area on groin injuries as well. So thank you, everyone.